Hi, everyone. Welcome to the Illusion of Consensus podcast. I'm here with a very special guest, Dr. Camilo Ortiz, who is a professor of clinical psychology at Long Island University. I came across his work first in Abigail Shrier's book, Bad Therapy, Why the Kids Aren't Growing Up. He's included in chapter 3 of the book. And this is a very interesting topic to me about psychotherapy at large, but also in kids as well. And I'm obviously a younger person. I'm 23. And since I graduated high school in 2019, I've just been on this path of self-discovery and recognizing various issues or things in the past that were holding me back. And I've been sort of unpacking the various layers of my family background and friends and things from high school and things that have had an impact on me that I didn't know had an impact on me. And I've really tried to take responsibility and work on various things in my life when it comes to issues surrounding obsessiveness or desperation or chronic anxiety and sort of sympathetic arousal. Or on the other hand, dealing at one point a couple of years ago more with isolation and depression, a lot of things that were heightened during COVID. But I've been on this path exploring different therapies, and I'm going to ask Dr. Ortiz about the different kinds of therapies. One in particular, which I'll maybe touch on if Dr. Ortiz has any thoughts. Many people who follow me know that I've been very openly talking about psychedelic assisted therapy, which has helped me a lot. So that's generally, I'd say, over the past few years, as I've realized that there's various things holding me back. I've taken interest in therapy. And obviously now with Abigail's book, there's been a greater interest and focus on broader questions about therapy, if therapy can harm, finding a good therapist, what therapy is for, how it can help people, and particularly about kids and adolescents, which is very interesting too. So Dr. Ortiz, thanks for being here, and looking forward to, I think, exploring this topic for the first time on the podcast, putting aside previous episodes on a couple episodes on psychedelic therapy, but this is the first one just on psychotherapy and on kids in particular.
Sounds like we have a lot to talk about.
So how did you come into contact with Abigail? That's how I found out about you. So I assume she reached out to you while researching her book?
Basically, everybody I know in the space is a function of knowing Lenore Skenazy, if you know who that is. If you don't,
say that again.
Lenore Skenazy.
No.
So Lenore is an amazing woman, and she runs an organization called Let Grow that focuses on increasing independence in kids. And so she works with schools to have teachers assign homework assignments where kids have to do things independently without their parents. And I've been talking to Lenore for years about this. And so I took some of her ideas and I said, well, what if we turn this into a treatment for anxious kids? What if we bombarded them with independence? And so I created this treatment called independence therapy, and we started to test it. And so far, we're really excited with the results. And as opposed to the traditional psychotherapy approach, where a kid will come into your office and you'll talk about the thing that they're anxious about, I ask them a different question. Instead of like, what makes you afraid of the dark or monsters or being kidnapped? I say, what are things that you would like to do independently? And every kid I ask that question to has some ideas. And so then we say, well, let's talk to your parents. Let's see if these things are okay with them. And let's plan some out every single day. And so then they go do some independence activities. Could be, these are sort of middle school kids. Could be taking the train by themselves. It could be going food shopping. It could be cooking a meal from beginning to end, starting a business at school. We have a list of 100 things. And then they come back and I say, how did it go? And what did you learn about yourself? And we're finding that when kids do this kind of stuff without a parent hovering, they do really well, and their anxiety comes down and their parents' trust in them goes up. So very excited about this new kind of treatment.
That's very interesting. Let's spend a quick minute here on just if you want to give a deeper overview of your background. So I said professor of clinical psychology at Long Island University, and you do a lot of research into therapy in kids. Can you expand on that a little bit more so people
Yeah.
know more about you?
Yeah, so we have a doctoral training program in clinical psychology at Long Island University. So I don't teach undergraduates, I teach people who are getting their doctoral degrees. And my research traditionally was in parenting and in disruptive behavior in kids. So kids who are defiant, non-compliant, aggressive. But as we all saw shifts in the world, I started becoming more interested in why kids were becoming more anxious and what we could do about it, and why we were spending all of this effort among my colleagues, and we were not getting better results. And so that sort of led into my independence therapy, where I said maybe we need to look at this problem a little differently. In addition to being a professor, I also am involved in something called the Open Therapy Institute, which is a place where we refer people who want therapy to providers around the country who have a commitment to not letting the therapy room become a place where the therapist's own political views play a role. This is person-centered therapy. You come to us and we focus on your problems. We don't try to indoctrinate you, and we certainly don't let our own politics invade the room, which is how it used to be. And so this might be something to talk about, but there has been a recent change in the last 15 to 20 years where many therapists believe that being an activist therapist is the way to do therapy. And I'm very troubled by that approach. And so we have tried to do something about it.
Yeah, I'm not like super interested in that, but I'm concerned about it, so we should talk about
I appreciate your honesty.
Yeah, I mean, I'm interested. Like, this is part of therapy, and like kind of what I've been going through is taking ownership of my own mental health and focusing on various issues. And I mean, we can get into that in a sec, but can you expand on this new sort of trend of activist therapy? Is this something that you're seeing a lot in your field? I anecdotally haven't seen a lot of it. Obviously, this is a newer topic for me, but can you talk a little bit about how this kind of activist therapy is increasingly sort of invaded in your field? Because I have heard of a lot of stories about this. Obviously, we have the gender affirming care, which is kind of inherently ideological, I'd say.
Right. Yeah. So I would say it's pretty clear that there has been a shift in that direction. And in fact, a lot of our professional organizations, including the American Psychological Association, have come out suggesting that an ethical therapist is an activist therapist. And it's become part of our ethical code, really without a ton of discussion about the pros and cons, that a therapist is supposed to aim for societal change. And that is a paradigm shift from how therapy has traditionally been done, which is to focus on the patient's own agency to make change in their own lives, as opposed to changing the structures around a patient. And not that there isn't a role for that, but when that becomes the default, really without a client's consent, it changes the entire dynamic between therapist and client. And we've had, horror stories of therapists dumping clients because of who they voted for in an election or because of a particular belief they have. And much more common than that, really, is a client feeling like they can't share themselves because they will be judged harshly by their therapist for not having the correct beliefs. So I find that very troubling.
Interesting. Yeah. Okay, so I got a lot of questions, a lot of thoughts, a lot of food for thought, a lot of reflections. I guess we can just sort of jump into one area and see where it takes us. So one, I could say, problem that I'm seeing a lot in the sort of therapy critical discourse is when people make statements like therapy can cause excess rumination. Therapy can actually worsen your anxiety. It can force you to, or it can lead you to focus obsessively on your problems when really you should be, going out. You can run errands, you can go exercise, you can go meet people, and how therapy can sort of make you focus on your feelings in this obsessive, overly fixated way. It can force you to become even more narcissistic or egotistical. I see a lot of these things discussed, and I like that. I would agree that it can do those things. I think it can, but it's sort of like saying like going to the gym can cause injury, and going to the gym can cause tendonitis. It can cause this, and you can fall and you can hurt yourself. And that's true. It can do that, but obviously there's incredible benefit, and everyone has their biases and their experiences. But when I sense a lot of people who are criticizing therapy are sort of leading with that and not really giving an honest assessment of like the real benefits. And I feel like some of those people, they do draw out very specific carve outs to, like, if you have serious obsessive compulsive disorder or bedwetting, and we'll talk about kids, but if you have schizophrenia, bipolar, etc., then therapy could be beneficial. But for a lot of other people, therapy can cause more harm than good. And I guess just my experience, some of which I'll maybe ask you about, but some of my experience, or just my experience in general, has been so positive that I want people to give an honest take on what's going on, and actually talk about the benefits and the risks. And it just swings from different sides of the spectrum depending on where you go. You have this very therapy critical discourse. Some people like Abigail Schreier, another one of my friends, Freya India. She's a great independent author. Many people that I respect and I'm friends with, and I love their work. But obviously it feels like a very different picture than other people. You could say sort of in the popular culture, that's more about talking about your trauma, being open about your feelings, destigmatizing therapy, talking about how you've been harmed, and recognizing how your parents may have harmed you more than you thought they had, toxic parenting, etc. And I see kind of both sides of the discourse sort of having their own biases and focusing either on the risks excessively, or potentially on the other side, overgeneralizing about trauma. I'm curious sort of your general thoughts on this as we I guess get the ball rolling on this.
Yeah. So that you said a lot there, and so let's start with the piece of it that I think is the least controversial and clearest, which is therapy overall, on average, is effective for many problems. And the gym example is a good one, because any time you intervene with anything, with an aspirin or with electroconvulsive therapy or with simple talk therapy, there is a risk. And this is the main problem that I think Abigail has so correctly pointed out. The risks of therapy are never discussed. And she uses the consent form that I use in my private practice on Long Island, where I specifically put it out there that there's a small but non-zero chance that therapy can make you worse. And I don't know of a single other therapist in my field who upfront talks to clients about the risk of starting therapy. And there are lots of reasons for that. But, I think what she has done is at least put on the map that this is not just like either it doesn't work or it helps you. There is a chance that therapy can make you worse, and people need to know this going into it. And in particular, they need to know this about children and child therapy, because children are generally not going into therapy of their own free will. They're being brought there by their parents. And there are bigger risks when there are children involved, because there's an even bigger power differential between a therapist and a client when a client is a child. So I don't really think anyone could disagree with the fact that there are some risks in therapy. And this has been documented for 100 years in my field. This is not a new finding, but we just don't talk about it. And I think there are self-serving reasons why we don't talk about it. So I'll start there. How about that?
Yeah. No, that's interesting. do you feel like when you're initially talking, like in your first session and you're discussing the risks, I mean, is it do you, do you see it as similar to other areas of medicine? And like the gym example that I gave, like is it worth discussing those risks then? And I mean, one other issue in here is that sometimes, like in my experience, you could say, even specifically with some of the psychedelic assisted therapy, which is very kind of a niche area, but it's very interesting. There's a saying often in the psychedelic world of, it often gets worse before it gets better. And
Yeah.
when you go into that area, and I don't know if you have any experience in that area, but when you go into that area, you find things, you find painful things, you uncover things very difficult. You don't know what to do with it sometimes. But you're unpacking these layers, and that's kind of the powerful part of doing that kind of work, is like you feel kind of forced to deal with it. Like, oh my God, like I need to figure this shit out. This can't just keep staying in the shadow, because I'm going to keep on reinforcing these views and treating people this way. And so there's that element too. Is that part of what you're talking about? Or
Yes.
like, and is that calculated within your practice? Is that sometimes starting therapy, it's supposed to actually get worse in a way, or it's supposed to potentially get worse, like as in you're unpacking things that are very difficult, and that might make you miserable that day, but it's better for you to overcome that.
I mean, there's sort of like two versions of therapy harming you. And the first one is what you're describing, which is it temporarily will get harder, but that's actually part of the plan. And then we have a clear way where this gets better. That seems more tolerable, but even that therapists don't usually explain to clients. But then there's the other part of like, it could get worse for you, and then it just stays worse. Like you could be actually harmed by this therapy, and that's even discussed less. But if I may, I'll give you one example.
Sure.
When we work with anxious kids, one of the things that we do is we work with their parents, and we work with their parents on reducing what we call parental accommodations. So anxious kids have this great ability to create a world around them that sort of caters to their anxiety. And it's totally logical to do that. I don't blame them at all. But parents are often sort of like softening their lives so that they don't have to face the things that make them anxious. So like, for example, if a child has some social anxiety, then a parent might order their food for them when they go to a restaurant. Totally reasonable thing to do. But that actually deprives a child of very good practice of doing something difficult, like talking to an adult. So one of the things we'll do is we will sort of make a list of all of these accommodations, and we'll say to parents, let's slowly get rid of these things because your kid needs more practice with these difficult situations. The first time a parent does this and tells their child, you're going to order today for yourself, many times kids have a tantrum, or they say, I'm not going, or they escalate. And therapists don't always warn parents that this is what's going to happen. And so a parent will come back and say, that was a disaster. She threw a fit in the middle of the restaurant and I didn't know what to do. And so at the very least, we should be preparing parents, because that's how it's supposed to work. But then there's the stuff that Abigail Schreier talks about in her book, which is more like literally long-term harm from therapy that is not part of the plan.
And so let's talk about some of the harms, and I'm curious what you've seen. So what do you see as some of the most common harms? That's a question I'd love for you to expand on. And also, I guess part of me is just curious and wonders like what is that like for someone? What you alluded to earlier about they start therapy, it gets worse, and then it stays worse. Like I wonder, like again, part of me, based on my own experiences, and I'm speaking of adults here, but is also a little bit different. But when I think of various people that I know or have heard of like dealing with serious depression, so you go to therapy, and it can be hard for a while. It can be really hard for a while. Like, yeah, my parents like really mistreated me, and my mom really didn't give a shit, and like that sucks. And I'd rather just go to my job, go to my law office, and be a lawyer. But like, fuck, this really sucks. And it might suck for a while. So I guess I'm curious what that case might be like, where it sucks for a while, but without any benefit, which is what you were alluding to.
Well, this is one of the things that troubles me about my field, and where the sort of contingencies I think are all wrong, because I often hear psychologists talk about their clients who are not getting better. And it's common to have what we call case presentations, where someone will present a case in front of a bunch of other psychologists, ostensibly to get feedback on what they could be doing. And often the feedback is, if the client's getting better, that's because you're doing a great job. And if they're not getting better, it's because they need more therapy. And so we've sort of like created this perfect system where no matter what happens, they need more of us. And so we might just happen to make more money that way. So it's a system that is resistant to accurate feedback. And we see this in lots of ways. So this might be a shock to you and to many people listening. But when we look at the effectiveness of therapists, it tends to peak about 2 years after they get their doctorate. And then it starts going down. So you think like a more experienced therapist is better. That's not actually true. There's a little dip up at the end when they're around the 50s, age 50 and so. But one of the reasons that has been hypothesized as to why therapists don't get better with more experience is that the feedback we get from clients and from other therapists actually is destructive to our desire and ability to get better, because we tend to only hear about the success stories. If we do a bad job and someone drops out of therapy, we don't really get a lot of feedback about that. But we get lots of letters from people saying, you changed my life, this was amazing. And those are real stories, but it's not accurate, the feedback we get. So our field is kind of like set up to create an illusion that we are better than we actually are.
Yeah, that's a really good point. Yeah, interesting. So let's talk about the harms. So what are the most common harms that you see?
Yeah, there are many. I think in terms of common, one is that therapy can start to serve as it can sort of feel like real progress when it's not. And so, for example, I see people say, well, I'm in therapy, so I'm going once a week. I'm working on this problem. But that's not really how behavior change works. In order to change an intransigent, difficult behavior, 45 minutes of talking to another person is about the worst way that we could think of if we had to rank how we actually change behavior. We need practicing, lots and lots of practice between sessions of doing difficult things. And a lot of therapy that I hear about is sort of pleasurable. How was your week? Oh, that's terrible. You know, you're right. The other person's wrong. It looks like what friends might look like if they were talking to each other. And this is,
I just want to pinpoint, like, when you say that could be one of the worst things you could do, talking to someone for 45 minutes. Again, just speaking from experience here, I found that to be, one of the best things to do, as in like taking a step back. Why am I behaving this way? Because that's part of the problem, right?
Yeah. Let me clarify. In the absence of other efforts. So like what I tend to see is people will come in for 45 minutes, vent about something with no plan to change it, no practice during the week, and then come back 45 minutes a week later and vent about that same problem. Now, sometimes that is people just need a little bit of support, and that makes a lot of sense to do. But what I sometimes see is years of this with no actual discussion. And this is something Abigail talks about in her book as well. When I see someone for the first session, what I say to them is, how will we know that we're done with therapy? What are the indicators that whatever problem you're bringing to therapy, that it's better? Because if we don't have that, then how are we to know if we're moving in the right direction? I mean, usually it's some vague sense that I'm feeling happier, but that's not a great way to tell if we've actually made the structural change inside someone that we need. And so it can be this illusion that we're working on something through talking about it without action. And I find that that's a poor way to change long-standing cycles of behavior.
Yeah, so you're saying people who come every week, come to their sessions, but they haven't actually made steps to change their life after the fact?
Between sessions. I mean, nothing that is difficult to change really can be done without practice. And it doesn't have to be every day, and it doesn't have to be super hard. But if there's no plan between sessions to institute something that you talked about, then it just ends up being talking without behavior change, which actually, so this is one of the harms. It can lead a client to feel dependent on a therapist. So I hear a lot like, well, I can't make this decision. I have to talk to my therapist first. And I really cringe at that, because one of the fundamental goals of therapy is to create independence in the client so that they don't need you anymore. As I tell people, it's a terrible business model, but when someone sees me, my goal is for them to not need me anymore. And I'm not sure that a lot of, people in my field think about it that way.
Right. Now, some things, okay, let's maybe reframe this. What can you give an example of this, if you have one, of someone of some particular problem? I mean, like anxiety, OCD, obsessiveness, something like that. What, can you provide an example of someone coming in every week but not actually taking the steps to improve that issue?
We'll have to be careful to protect confidentiality, but I can tell you that where this tends to happen is when people have interpersonal difficulties with others, and so they're sort of enacting the same kind of relationships with other people that are leading to problems. So let's just say, for example, someone is overly dependent on their friends. And so what ends up happening is their friends get kind of irritated with that interaction, and then their friends push them away. And so they might come into therapy and say, I don't know what it is, but every time I get close to somebody, they don't want to be that close to me anymore. They push me away. And so, an example of this would be like a therapist suggesting that it's everybody else's problem and you're doing everything that you're supposed to be doing. And that is, rarely the case. All relationships are interactional, and we all play a role in the outcomes. And so I see a lot of this like supportive therapy that ends up just being a bunch of cheerleading. And real
that sounds
therapy
like a really bad thing. Like, so you think that's happening? So someone like in the example, yeah. So like in the example that you gave, someone who's overly dependent on their friends, and like there are cases where a therapist would just blame the friends rather than actually realize that we have a problem here.
Yes, or if not overtly blame friends, but be just supportive and be like, you're trying your best and it's really hard, but don't actually push the client to really examine these difficult, uncomfortable truths about how they present to other people. And so, like good therapy is kind of like the gym, in that you should leave like pretty worn out and exhausted, but proud of yourself. And if you go to therapy every week and you just like feel great at the end, and your therapist is just like so nice and so supportive and tells you everything you're doing is great, I don't think that's good therapy.
So in the example you gave is very interesting. One that evokes a lot of feelings for me personally, but so like in that example, someone's coming in and they're saying people are always irritated with me, and usually I find people with all kinds of interpersonal issues, and I can think of several. Usually, to some degree, the person's very aware of that. They're very irritated with that. They're frustrated with themselves. It can lead to self-loathing, vicious inner criticism. And one positive thing that I've experienced in therapy is bringing in some more self-compassion and sort of bringing this compassionate curiosity, and really having a therapist, guide me in investigating internally of where that's coming from. And I wonder, I mean, this is kind of a deeper question about different approaches to therapy. And what I see, the clinic that I go to, they don't actually do CBT. I've sort of learned CBT things on my own, and I see CBT as a great tool for working with anxiety in real time and learning how to reframe anxiety. I think there's a lot of power there. Particularly, I guess, as we'll talk more here, I'll just mention that like the work that I've done, it's primarily IFS, internal family systems. I don't know if you particularly have any opinions on those things. Have you
Not
worked
in
with have you
particular.
worked with IFS? Have you done
I have
IFS?
not. No.
Okay, so you CBT and dialectical therapy.
Hi, everyone. A quick word from our first and exciting sponsor, Alchemy Elements. Alchemy Elements is a powerful adaptogenic supplement. For those of you who don't know, adaptogens are a class of plant compounds, primarily herbs and mushrooms, which can help build the mind and body's resistance to stress. Alchemy Elements contains a very unique and carefully selected blend of 9 adaptogens, such as lion's mane, cordyceps, polygalaroot, and shilajit, and they can help boost energy, boost your immunity, and increase focus and overall stabilize your mood. It can have a wide array of effects, which can often depend from individual to individual. But it's a great way to start your morning and generally increase your focus and your energy levels. You can just pour 1 scoop of Alchemy Elements into your morning coffee or your protein shake or smoothie, and you're off to the races. It's a great way to start the day. I use it every day. I find that it can generally stabilize my mood levels and increase focus, especially if I want to get a big project done or finish a very important task. Alchemy Elements often is a great way to kind of start and get my focus going and get me primed for whatever task I want to accomplish. We're very excited and very happy to work with Alchemy Elements. We've been working with them for a couple of months, and now in this new iteration of the podcast, we're going to continue our relationship, which is very special to us because Alchemy aligns with our mission and values of individuals taking greater ownership of their personal, mental, and physical health and relying less and less on corrupt and flawed, generalized kind of medical advice. And less reliance on pharmaceutical drugs, and more of general interest and focus on holistic health. For a limited time, Illusion of Consensus readers and listeners can get 10% off their first order using the code word illusion, or 30% off a subscription monthly order, where you can get a monthly shipment of Alchemy Elements delivered to you. For the subscription orders, you can also get with it a bonus gold kit to store your Alchemy Elements. Overall, I think Alchemy is a fantastic product. I highly recommend you check them out in the link below in this podcast, wherever you're listening, Spotify, Apple, Substack, Rumble, or YouTube. Just go to the link, use the code word illusion, and you can get your discount and you won't regret it.
So cognitive behavioral therapy is the big umbrella term, and DBT or dialectical behavior therapy is a smaller piece of cognitive behavioral therapy, but they share a lot of the same foundations, which is in part the way we think about things is at least as important as the things themselves. And so that opens up lots of ways to intervene. I just wanted to say something about react to what you said. So
yeah,
I think this distinction between reassurance and compassion is really important. And so I love what you said about how your therapist has been helping you, or you've heard of other people, to be more compassionate, because we tend to, all of us, be really mean toward ourselves. And that ends up rarely helping a problem. And so helping us to be empathic and compassionate with ourselves, just like we often would be with other people, is a wonderful aspect of therapy. What I often see is not that, actually. It's reassurance, which is, no, you're actually not socially awkward. You're not annoying to be around. You're actually not anxious. It's going to be better. Don't worry about it. That's a totally different thing than actual examination of someone's inner workings with curiosity, which was another word that you used. That's a wonderful way of understanding therapy, that if the therapist is curious, that's going to be very helpful. And reassurance is often not curious. Reassurance is to make a bad feeling go away. No, it's going to be fine. That's not curious. That's reassurance. And I'm not sure that's helpful.
Yeah, that sounds horrible. That's not what I think of when I think of therapy. But the fact that that's happening, as you, I'm taking your word for this, that sounds very counterproductive.
Yeah, don't take my word for it. I think many people will tell you that a lot of therapy ends up being a reassurance fest, that really, again, looks like what a conversation with a friend would look like. And if you're a friend, you should reassure. That's a great role for a friend. That's not a great role for a therapist.
Now, you were talking about someone who's annoying or just uncomfortable to be around. Obviously, you wouldn't say that that's the therapist's job to say, "Oh, you actually are very annoying." Like that also doesn't seem like.
Well, there is a role for confrontation, but if you do that too early or before you actually have a good relationship with the client, you're just going to push them away.
Right.
But one of the things I like about dialectical behavior therapy is it has an irreverent quality to it, and so you can, as a therapist, use your personality and sometimes say some shocking things to a client to get them to get a different view on things. Now, you don't want to do that all the time. That's annoying in and of itself. But there is a role in direct feedback. And another way that we do that, and I did this
I'm curious how that looks like, by the way. I'm curious what that would look like.
The best example is the person who invented DBT. Her name is Marsha Linehan. And there's a well-known example where someone was quite suicidal. And she was talking about how, she might want to end it this week. And Marsha Linehan said something to her like, "No, you can kill yourself next week, but let's work on some things now, and we'll see if that leads to a different outcome." And so that's a shocking thing for a therapist to say, but there's also like a real grain of truth in it. Like nothing says you have to do something right now. So that's an example, but that's an extreme example.
Right. But again, like with the earlier example, which I assume like that topic is very common. Someone is presenting to other people in a particular way that's leading to fractioning of social relationships. So like, you talked about someone being annoying. It's not it's not like, I don't, at least in my conception and experience, it's not the therapist. Like often the person has a lot of shame because they've gotten that feedback from other people. Oh, you're really annoying. It's difficult to be around you. And it's like that person's carrying that guilt and that shame and just sucks. And I feel like, the therapist should come in at that point and have that compassion, curiosity, not just like, yeah, you actually are very annoying. Yeah. You're but like, actually like, where is that coming from? Like, why do you feel like when you're with your friends, you have to cling on and you have to keep talking to them? Like, where is that coming from?
Well, this is, I think what can make a therapist quite good is you can be really compassionate and empathic and also be quite direct with the client. So, we talk about one of the core tenets of good therapy is to be non-judgmental, that no matter who's sitting in front of you and no matter what problems they have had, they probably are doing the best they can with the tools that they have. And so if you start from that approach, that the person in front of you is doing the best they can, then you can simultaneously, and this is where the word dialectic comes from, which is two things that appear to be contradictory yet are both true. You're doing the best you can, and you need to do better. Both can be true at the same time. And so if you approach a client with that compassion...
Sorry, say that again. Actually, that strikes me as a contradiction, but I need to think about that again.
That's what a dialectic is, something that sounds like a contradiction, but actually could both be true. So you're doing the best you can, and at the same time, that's not working for you, so you need to do better. Does that sound like a contradiction?
Well, but if you're doing the best you can, how can you do better if you're already doing the best you can?
With hard work in this therapeutic relationship, we're going to get you to a place. So some people think if you're doing the best you can, there's nothing that can be done about that. The dialectic is you can be doing the best you can, and we can still figure out ways for you to be more effective in your life.
Oh, I see. Is what you're implying, that you're doing the best you can now, or at least maybe you are, but as in you need to do better, as in like in the future. Is that
going forward? If you want to reach your goals, if you want to live according to your values, doing what you've been doing is not going to get you there. So we acknowledge you're doing the best you can, but we got to change some things.
I see what you're saying. Yeah, the confusion I think for me was like, if you're doing the best you can now, how can you do better now? But that's the implications there through the therapeutic relationship. You're going to look at these things, and that makes sense. Sorry,
so I'll just give you one example.
Yeah, go ahead.
Like this week, and this is something I do a lot with clients, is we will record a therapy session and the camera will be pointed at the client. And so their homework assignment will be to watch themselves in therapy. And they often gain a lot of insight about how they come off to people and facial expressions and posture and things like that. And this is not easy for them to do. This is actually painful for anybody. I'm sure when you started doing this and you listened to your first podcast, you didn't love what you heard.
Well, I barely listen to myself. It's very weird.
So this is maybe a good piece of advice. You should, because as uncomfortable and painful as it is, that direct feedback is one of the best ways to change behavior. And so they might say, I didn't realize I have poor eye contact, or I looked down at my shoes until I saw myself doing that. So that's a good example of therapy being difficult and uncomfortable, but good for somebody.
And going back to that example that you brought up, which I found interesting, the friend who's overly dependent, or the person that's overly dependent on their friends, and so someone like that comes into your office, and we can say 14-year-old, let's say, and they're really struggling with that. And I guess this is maybe even hitting on another deeper question of cognitive behavioral therapy and the scope of that. So like I do internal family systems, and at this great clinic called Thrive downtown in Vancouver, and some of the therapists there and other people have criticized CBT for being sort of shallow or superficial, especially when it comes to unpacking the layers of trauma and past experiences that have led someone to behave in a certain way. I guess maybe that's one place we can linger on for a sec. Do you think that, like, for someone who's been through trauma, and we can define trauma if we want, but do you see limitations in CBT and your specific kind of therapy versus other kinds of therapies, and for trauma, for OCD, for those kind of things?
Well, so I could start with an empirical answer, which is that the data on cognitive behavioral therapy for trauma and OCD are the best of any treatment. So empirically, the answer is no, it's not limiting. It works really well. But let's just unpack that a little bit. So this is maybe the single biggest misconception and myth about CBT, which is that we only care about what's happening right now and we don't care about the past.
Yeah, that is
just
what I've heard.
True.
Okay.
Not true.
Okay.
So the piece of that is true is, in comparison with other therapies like psychodynamic and psychoanalytic therapies, we do tend to focus more on the present than on the past, because we want to be practical about what are you going to do this week about this problem. But it is absolutely true that when what we call conceptualize or formulate a client, this is language we use, how we understand a person, we go back to genetics, even to early life experiences, because those things, genetics, yes, there's it's very clear that there are some psychological disorders that have a bigger genetic component than others, and OCD is a good example of that. But it would be silly to say that your early life experiences have no effect on your current functioning. So it just doesn't make sense that we would, as a group, ignore that. And those early life experiences set up the lens on how we view the world. Absolutely true. Nobody disagrees with that. Having said that, we're going to focus on this week what happened, not generally, although if there is a trauma that happened, we definitely spend a lot of time on that. But for a typical client, we're going to focus on, tell me about this week what you had trouble with, not when you were 6 years old.
Yeah. I guess I can bring my experience into this and ask you some questions. Like, for just personally speaking here, I've never had any interest in going in the past and unpacking things, but I've realized that in my therapeutic journey that appears to have been and is vital work to do that. Like I felt called to it suddenly, because oftentimes, it's one of the many problems of sort of freezing yourself in time, of like, I'm really stuck, I'm really struggling with anxiety or this obsessiveness or whatever issue we're talking about. And you're just confused and you're stuck and you're frustrated, and that builds the self-criticism and the shame and the guilt. But it's like, you unwind the clock a little bit here. You kind of go a year back, 2 years back, 10 years back. And it's like, my grandma was like that. And my best friend, he told me this thing. And It's like it makes more sense why you're struggling
Sure.
with a particular problem. Would you agree?
I mean, that's one of the big advantages of talking about the past, is then things don't feel so confusing anymore, because you can find a thread through your life that is leading to what is happening today. In and of itself, talking about your earlier life doesn't really give you solutions, though, as to what to do. And so that's why cognitive behavioral cognitive behavioral therapy focuses on now, which is insight is important, but it's not enough to tell us what to do about these ingrained behavioral patterns. So that's why, we have to be practical. What are we going to do tomorrow?
Right. Yeah. This is super interesting to me, and I can use my own example here of like, I've struggled a lot with anxiety. Particularly, I've struggled with chronic pain, chronic chest pains, and digestive issues. I did a podcast on this just this week with Dr. David Schechter. I don't know if you're familiar with there's so many different names for this, but the mind-body syndrome, mind-body medicine, psychosomatic issues, psychophysiological disorders. People with digestive problems, lower back pains are the most common ones. Cluster migraines. This is the work of Dr. Howard Schubiner, Alan Gordon. They've pioneered this area. This actually goes back to Dr. John Sarno. He's one of the earlier pioneers of the field of actually the majority of people with chronic back pain or tendinitis or cluster headaches or digestive issues or chest pains. The cause is actually fear and anxiety, it's not something in your head. It's like, there's nothing wrong with your brain. There's nothing wrong with your back, even if you have sort of smaller issues that you can detect on the surface. Are you familiar with that work? Some of that, that work is fascinating. That work just completely changed my life. Of instead of focusing obsessively on, oh my God, like my digestion's fucked up and upset stomach and all these issues, and like, oh my God, what's going on? And then sort of unpacking. And thankfully, I had a friend come in my life who he struggled with that, and to the point of getting back surgery and getting steel plates inserted in his back because he had debilitating back pain, and it went away for a while. And he tried all the physio, all the doctors, chiropractors, etc., and it led him to this work. And he started unpacking, and it was actually fear and anxiety, and overcoming those issues cured the back pain, not the fucking surgery that did it.
Well, I mean, that fits in very nicely with what we do in cognitive behavioral therapy, which is that the general model is that there is generally something going on, and then we can make it much worse with the way that we think about it. It's what we call the two-problem solution. And so if we start working on our thinking and our philosophy of how we think about the world, even if we have a real problem, even a real physical problem, we can make it much better by shifting the way that we think about things to be generally more preferential and flexible than rigid and dogmatic.
So going back to my example, I think this is a fascinating area to linger on. So having struggled with, I actually didn't even characterize that as anxiety, but it did produce anxiety. So I struggled a lot with chronic chest pains and digestive issues to the point of serious heart palpitations, and then the fears of, I might have a heart attack, or just chronically there's something wrong here and the doctors can't find it out, and oh my God, what's going on? And that elevates the heart rate more, being unable to sleep at night because you're feeling your heartbeat and you feel in your ear. It's like, it's like, this feels like complete hell when you're in that state. So some of this mind-body work, which is, you could say, sort of a specialized application of CBT principles, at least. So Alan Gordon, are you familiar with that name? He wrote the book The Way Out, which is probably the best book on, very simple, easy to understand book on chronic pain, how to get over it. And basically the treatment is, number one, knowledge of, like, first of all, realizing either through making a log of your symptoms and realizing you have many, many psychosomatic symptoms, or working with a therapist or a doctor who knows what they're doing in this area, which is rare, but this is increasingly people are versed in the mind-body system. First, informing yourself of, like, actually this back pain that you've had, it's been there for a long time. It's not just because you go to the gym. It's not this or that. And so you're sort of ruling out physical causes. But then the deeper part, the important part, is reprogramming the patterns of fear to patterns of safety. And so that was my journey. And, it seems like a very CBT thing of essentially what Alan Gordon talks about is somatic tracking. There's different names you could call it, but essentially experiencing, the area of pain, that area that's hurting, when it comes to chronic pain, but this also just goes to anxiety more broadly, and viewing it through a lens of safety. And sort of one term that he uses is being outcome independent, of like, this hurts right now, this is really painful, but I'm gonna view it through a lens of safety, and I'm gonna take some deep breaths and relax and recognize that it's going to come and it's going to go. I don't need to hold on to it. I don't need to keep thinking about it. I don't need to be afraid of it, crucially. And that's a really hard process at the start, when you're afraid of a particular problem, when you're afraid of your anxiety or whatever it may be. The fear is just so inextricably connected to the problem, and separating that fear out and establishing a lens of safety and calmness and relaxation, that feels like a mountain to cross, but that's a big part of the. And so before I go to the next thing, is that sort of aligning with CBT principles?
Absolutely. And in particular with anxiety, what we hope people do is they move from a place of fear to a place of discomfort. So if we take, for example, a panic attack, typically when someone comes to see me with panic disorder, they're afraid of a particular outcome. So their bodily sensations are telling them, you're having a heart attack, you're going to faint, you're going to go crazy. And we do a thorough assessment to make sure there's actually nothing physically wrong. And then over time, with exposure therapy, we get to a place where it becomes more like, oh, this is annoying. I really would prefer to not feel this way right now, but it's not dangerous. And that shift is tremendously important. People can tolerate being uncomfortable, but it's a big difference to fear that something actually terrible is going to happen to you. And so basically the way that we often do that is by having people have panic attacks on purpose over and over and over. And we test this belief that they're really dangerous. And with enough data, people start to shift. Oh, I've had 20 of these by now and I'm still here. And so that probably means they're not dangerous. And we know the physiology of panic. The fight-flight response is there to protect you. It's an evolutionary advantage that we all have. It just wouldn't make sense that it's actually dangerous. It's meant to get you out of trouble. Now, you can say that to somebody. It's not going to change their mind until they practice having these physical sensations in the safety of a therapist's office, and sometimes outside of a therapist's office.
Now, you mentioned the negative, so this is not dangerous. Do you also like to use positive affirmations? That was a big part of my process. Positive affirmations of I'm safe and I'm healthy. I'm not going to die of a heart attack. This is not dangerous. But crucially for me, it was I'm safe and healthy. That affirmation was really
like
powerful.
To test predictions as opposed to use affirmations. So someone says to me, when I have a panic attack, I think I'm going to have a heart attack, right? And so then I would say, well, let's test this. How would we know if you're going to have a heart attack? And then we test it over and over and over, and they come to their own conclusion that, oh, this actually is very uncomfortable, but it's actually not dangerous. That direct experience is far stronger, far more important than words I can tell you. And that's why cognitive therapy, talking through panic disorder, is not particularly helpful, whereas practicing being uncomfortable with panic symptoms is really helpful. So, I mean, I've learned a lot of affirmations in my career as a psychologist, and some of them are really interesting and cool, but in and of themselves, they don't tend to move the needle a ton. So I heard one the other day that I really liked. It was be curious, not furious. And, that's nice, and we can use that. But in and of itself, without practicing something, it doesn't really move the needle that much, in my experience.
Right. Yeah. And I'll say that I got turned on to affirmations. They seemed very silly and superficial to me. Like, what's the fucking point? But I was doing Dr. Howard Schubiner's workbook on chronic pain. He's probably sort of the most prominent, influential person in that area right now, you could say. He has some great podcasts, and he's a great workbook on this. And he suggested that in the book. And I think the explanation is something like, and I did a podcast recently with this sleep therapist who works a lot with inner safety, is that you can call it different names, but if you want to say, like, we have a higher self and a smaller self, or like the chimp brain and the higher self, we have this higher self, we have a lot of knowledge, like we often know what we need to do. When it comes to things like anxiety or obsessions or anger or lust, like all these different things, we get very hijacked by our emotions, right?
Absolutely.
And so at that point, so I think Schubiner wrote in his book about um, when we sort of get into that primitive state where we're, in this particular case, so like drowning in fear and worry and, oh my God, I'm gonna have a heart attack. Oh, it just feels like hell. It feels like literally like hell for a lot of people.
We call it emotion mind in DBT, by the way.
Oh, okay, cool. Yeah. So when you're in that emotion mind state, Schubiner was advocating for using an affirmation can be a really powerful way to start reprogramming that feeling of danger. And so it's again just from experience here, that was like and just saying the process of saying that affirmation, I found was really interesting because again, initially I thought it was silly and what's the point? Then I'm like, okay, it says in the book, let's just fucking try it. And I tried it, and immediately the feeling when you try it, like dealing with chronic chest pain and anxious and whatever, and like you apply it, I'm safe and healthy, and immediately when you say that, a part of your brain, you could say the emotion brain, it rejects that. Like, no, you're not. You're in fucking danger, man. You got to get the hell out of this place within your body, right, that's become this haunted house. And so, but saying that over and over again and kind of instilling that again when it doesn't feel right. It's like, no, I'm not safe. But then you're accessing that higher self, if that's the right way to conceptualize it. And it's like, no, you actually are safe. You're very safe right now. You're not going to die of a heart attack. You're going to be fine. You're going to get through this. You actually are safe. And so that process for me, I think, was very powerful in reprogramming a lot of that. And it's something I still use every now and then when I get sort of tensed up or anxious about something, and I got to tell myself that, and it's like, then things start to calm down over time. Does that make sense?
That makes a lot of sense. If you have fallen into this pattern of where your emotions are dictating what you do, and you need to put a break on that for a second, an affirmation can be helpful. I would suggest that we need to follow that up with lots of practice on whatever it is that we want to be different. And the affirmation in and of itself is what we call maybe necessary but not sufficient to get you to the point that you want to be. So this is another example of maybe like what I consider to be not great therapy, is a therapist who only relies on positive thinking and affirmations. That feels good, but I'm not sure it moves the needle very much.
Right. I think I would view the affirmations as part of, like when you say practice, like that is part of the practice, right? Teaching yourself that you are actually safe and this panic attack will go away and you're not going to die. Yeah. Right? That I'd include that as part of the process. And like I said, like part of that is what Alan Gordon's talked about as somatic tracking, right? So feeling the sensations of pain, which you alluded to, but from a lens of safety rather than a lens of catastrophic thinking.
Yeah, makes sense.
And so what I was trying to get at there is so when we talk about CBT, reframing anxiety can be a very powerful tool, sort of grounding yourself in the present moment and having a realistic perspective of whatever you're experiencing. So this particular work that I mentioned is very CBT oriented, has been incredibly helpful in overcoming hyper anxiety. And I mean, there was acute episodes, but I'd characterize it as chronic, as in it was just there all the time. It was there every day. But then this gets into the sort of deeper part of it, which is sort of the internal family systems, the particular modality that I'm working in, and some of the criticisms that people working in that area would have of CBT. I guess I can just trace it back to experience. So this anxiety that I've struggled with a lot, and reframing that through a lens of safety and realizing that I'm safe and that nothing bad will happen, and recognizing these catastrophic thoughts I'm having in the present moment. That's a lot of what CBT is about. That's been, again, incredibly helpful. But then where IFS seems to go deeper, and I'm curious if that in your understanding and your practice of CBT, if that's already included, a lot of the deeper work has been, where is that anxiety coming from, and what's it trying to teach me, and where, like what's it trying to do? What's the fear behind? And not to focus too much on the chronic pain thing, but one thing that Alan Gordon and some of these other people have talked about with chronic pain is that you often people in this area who they might have one part of one area of chronic pain resolved, but then it pops up in another area. and and I've experienced this more broadly. You have anxiety about one particular thing, and you do CBT oriented work, and that can get better. And then several months later, there's anxiety about something totally else, and that's part of the sort of character of anxiety, right? It's always trying to convince you of it's actually this thing. This is the thing to worry about.
The whack-a-mole problem.
Yeah, the whack-a-mole problem. Which again, that's like, I think, this working on that CBT level is very important. But then with the IFS stuff, it's been going deeper into, what am I afraid of? This is a lot of the process. And again, I'm curious if this is something you do as well. Of usually the therapist having me close my eyes and then asking, what is this part afraid of? This part of you that's really worried about this particular thing. Like where is it coming from? And then usually, oftentimes, there's a deep rooted fear that goes beyond the specific situation. Or if we want to use that example that you used, which is actually something that I've struggled with, about being overly dependent or obsessive or annoying, or these kind of issues. It's like examining inwardly of like, where is that coming from? And it's like oftentimes there's a deep rooted fear of like, oh, if I don't keep on doing this thing, or if I don't reach out in this certain way, then what if I'm just alone for the rest of my life? Or what if I end up depressed if I don't do this thing? Or if I'm not trying so hard, this is one particular example that goes to home. If I'm not trying so hard in my work, how am I going to get anything? Because I have to try really, really hard. And it's like working through that part. And often a lot of tears come with that part. A lot of like, oh my, I've been doing this for such a long time. I've been expressing this emotion this way. And now for the first time, we're sort of tracking where that's coming from and what are the motivations and fears underlying this particular symptom.
There's a lot of ways to answer that, but getting back to like what we do in CBT is we often do understand that there are many layers to a fear, and one of the techniques that we use is called the downward arrow technique. So let's say, for example, you come to me and you say, I get really anxious. Let's say you're in high school. I get really anxious when I take tests and my mind goes blank. So we might focus just on that anxiety, but I think a more important question would be, now, if you were to fail a test, what might happen? Well, then I wouldn't get a good grade in the class. Okay. And if you didn't get a good grade in that class, then what might happen? Well, then I couldn't get into the college that I want to go to. Okay, and then we assume that happened. You couldn't get into the college. I would disappoint my parents. And we keep going, and we keep going. Yeah. And at some point, we reach the worst thing that they can imagine. And then I ask the question, and if that happened, what would it mean about you? And usually the person will say something like, well, it would mean that I'm a failure. Okay. Yeah. And so now we have a lot of possible ways that we're not just talking about failing a math test. And so this is entirely consistent with CBT. People think CBT would be just asking about the math test, but everything else I said is what we do in CBT.
Right. That's really interesting. So that chain of questions, like, yes, I've done that a lot, and I found that to be very helpful in getting to that fear. And it's funny, like fear. I mean, this is a common thing, but like that. Yeah, I'm worried. Many people feel this way. I'm worried that I'll end up a failure. I'm worried I'll end up like a loser. I'll end up depressed and lonely, and I'll have no one to love me, like stuff like that. And that, I think, getting to the bottom of that, I found to be really powerful. I found that
it's also
very, very powerful.
Going back to self-blame, if someone goes through all those steps, and then I will often say to them, no wonder taking a math test brings so much anxiety. Look at all the possibilities that can come in your mind and all the meaning we've attached to a math test. It would be weird if you weren't stricken with panic when taking a math test. And then you see the person relax because now it makes sense. And then we go, all right, so what are we going to do about it?
Right. And that, that sort of getting at the sort of root cause, for lack of a better term, like that's often that narrative that we have of a particular fear. Like let's say the example you gave, fear of being a failure. I'm curious your thoughts on this. This is something I'm working on like very recently in therapy, but I often find, and tell me if this is consistent or common in your practice, of oftentimes the fears can end up causing what they're trying to prevent.
Absolutely. I mean, that's
Do you find that?
For sure. So let's say you're afraid of being a failure, and so what that might mean is that you decide that you're not going to try some things because failing them would be so painful to you, and therefore then you become a failure because you don't push yourself to try things. I mean, a lot of what we do in therapy is people's fears actually coming true because of the approaches they have to fear. And so that's one of the things that a good therapist will do. This makes so much sense. I wonder if this approach actually might be leading to the thing that you're worried about. Might we try something else? So happens all the time.
Yeah, I recently had a revelation on this. I would describe of, like when you unpack the fear, you often see that it's actually causing the problem that you're worried about. And that's like a big awakening when that happens. Like, oh, this fear, it's trying to protect me from this thing, but it's so strong that it ends up causing the thing.
And clinginess is a great example of that. So people who fear being abandoned or left by others become clingy, which only pushes them away. And then
I was
it
just
ends
thinking
up
of that
happening.
example. Yeah, go ahead.
Yeah, and so then unfortunately, the lesson they learn often is, I wasn't clingy enough. I need to be more on guard for people rejecting me. I need to analyze every last thing, and then it just happens even more.
And so in that particular example, what do you find is often the way out of a problem like that? And I'd say but I know people struggle with that problem. I have as well. That oftentimes people can be quite aware of that problem. Like, I know I'm like that. But and this just goes to show like just how mental health works. Oftentimes people are very aware of their problems. Like, I know I'm annoying. I know I'm very mean sometimes, or I know I have these angry outbursts, but they can't stop it. Like, I know I'm very clingy.
Yes,
and I know
yes.
People get annoyed with me, and I know, and sometimes you've done some work, and it's like, I know, I'm worried that like the reason why I'm clinging on so much is that I want to be validated. I want to be affirmed. And I'm worried that if I don't do that, that maybe I'll be abandoned. I'll be left alone. And so I really got to hold on and constantly follow up with people, because if I don't, then I'll be left alone by myself, and I'll end up like maybe some people around me that I might know. What do you often see as the way out of problems like that?
So we have to experiment with different approaches. So if being clingy has not worked for you, and we will spend a lot of time on that, but it's some version of how well has that been working for you. And usually someone will say, I'm here, so not so well. So then we can talk about what would be some different approaches and what gets in the way of trying those things. So if they say to me, for example, well, maybe a different approach would be for me to text my friends a little less and wait for them to text me. And then we'd say, well, what's hard about that? Well, I get so anxious when I don't hear from them. And then when I text them, I feel better. Even if they don't reply, I feel better initially. So then we have to work to tolerate discomfort of trying some different approaches. And then we have to sort of like set up an experiment. So how would we know if texting less actually was helpful? Well, maybe they would reach out to me more. Maybe they would be warmer. So we kind of like set up an experiment just like a researcher would. We call it a behavioral experiment. And it's hard for people to try these things. So we start out with some easy things. But there are, so I'll give you an example of one that we did. So I had a patient who was super worried about being judged on her appearance, and she's in college. And so we did this experiment where she taped toilet paper to the bottom of her shoe, and she walked around campus all day with a big string of toilet paper. And we made some predictions about what would happen. And what she learned was that people don't really seem to care that much what you look like. They don't even notice. And that was a really important lesson for her. And she didn't have any fear about toilet paper, so it wasn't specific to that. But she learned a broader lesson. And we only were able to do that because we set up a different approach using an experiment, if that makes sense.
Interesting. Interesting. Now, again, from my experience with IFS, which is at least viewed as sort of more holistic and working through layers of trauma, like there's an initial skepticism of treatments like that in my mind for some reason. Of oftentimes the emotion that leads to someone to be very clingy is very, very powerful. Comes from a very powerful place. Comes from a lot of adverse experiences or just role modeling and conditioning, and so. And I guess this is part of just my inquiry, intellectually and experientially and academically of like the solution. It can feel like the solution can be very hard to those things. And like understand, like, do you feel like it's very important, like when someone has this powerful emotion that leads to a behavior, like being being overbearing or being clingy, is it a matter of understanding that emotion? At least in IFS, that's a big part of the process. Understanding where it's coming from. What is it trying to do? So when you're behaving in a certain way, you're being very clingy. Like, why are you doing that? And it's like, and then often it takes a second. You got to take a couple deep breaths, and you got to really see. And it's like, again, that it can be that fear of like, if I don't do that, then I'm going to end up miserable and sad. So I got to try really, really hard to ensure that I have these connections stable and it's certain and it's clear. But again, broadening this out for a second too, like that's part of the struggle with some of mental health oriented things is it takes a lot of time. Like you can get a lot of knowledge and you can know like, it's my fear of abandonment and my parents did this and this, and but that part that's, working really hard and behaving in this way that, other people see as negative, it can be very hard to get over that.
Well, in CBT, we have this term we call the function of a behavior. And so all of that means is sort of like, what is the purpose for that organism of a behavior? And something like clinginess absolutely has a purpose. It serves that person to some degree, or they wouldn't do it. And typically what it does is it brings them short-term relief. So when I'm clingy, I feel a little bit better because now I have a connection to someone. But as with most problems, it creates a longer term, bigger problem, even though it solves a short term problem. And so if we understand that, that's important because then we can say, is there another way that we can get that same benefit that doesn't have that same drawback? And then that's when the solution focus of feeling close to someone. So we know feeling close to someone is very important to you. That makes a ton of sense. You've been trying to get that feeling by being clingy with other people. That's not working so well for you. But we can't say that that goal is unimportant. It is really important. So what are other ways to feel close to others that don't actually end up pushing them away? And that's where we can get into some experimentation of some other approaches, go into it with an open mind and see what happens. And sometimes we come up with some pretty good solutions.
Yeah. Interesting. Yeah. I've never thought about it this way. But so
I just have a hard stop in a few minutes. So
sure.
Coming to jump in, but
sure. But you often find success with the way you've outlined it here, those practical behavioral solutions.
Absolutely. I mean, it's not just me. The research literature is robust on. There actually are not huge differences between different approaches. CBT versus other approaches for most problems are pretty equivalent. There are a few things where CBT is clearly superior, like obsessive compulsive disorder. But a lot of what's important with therapy is the stance of the therapist, the attitude, the relationship, not so much the particular skills that they use. But what I'm describing is a collaborative, curious approach to the client sitting in front of you. And I think that's a really nice way to try to understand someone, to be empathic toward the other person, and to look for solutions.
And again, this is a very, very important spot to linger on a little bit more. Like that, like what's the expectation here as well? What's a good result, and how to, again, it seems like for mental health issues, it can be very hard to overcome some of these things. And it's like, how do our diagnoses work? Like, is there diagnoses for clinginess or being annoying or fear? Like, I mean, there's anxiety disorder, but like these are all human emotions. People struggle with it. Like, what's the expectation with that? I've personally found, getting over these things, like some of the things that I've mentioned, it can be like very, very hard to do that. So so when you say like you've had success, is the expectation that it'll come down by like 90%? It's supposed to be way, way better, but it can still come, or it's never supposed to come, or how does that work?
We really focus on functioning. And so when someone comes in, we say, how is this problem interfering with your life? And this gets back to that first question. How would we know that things are better? Well, I'd be reaching out to my friends more. I'd be going out on weekends more. I'd be exercising more. And so when we start hitting those milestones, we go back to the beginning and say something like, when we started, it seemed like these things would be indications that you're doing better. It seems like a few of them are in that direction. Is this a good place to stop, or should we push more? And the research on change in psychotherapy shows that in the first 10 sessions, you get the majority of your change. And this is another thing people don't understand. After that, you still keep getting better on average, but the slope is not as steep anymore. And so this is an important conversation to have with someone. If we go another 10 sessions, you're probably not going to get as much benefit, but is it still worth it to you? And for many people, it absolutely is. And then it makes sense to continue.
Yeah. Again, just speaking from experience, I've been at therapy for a couple of years now, year and a half, couple of years. And it's been just surprising and shocking at times to see like some of the big, deeper insights on some things come last week. And like we started 2 years ago. So
all those sleeper effects. And sometimes they can be quick and interesting. Yeah. And hard to predict.
Yeah. But again, going back to, I know we got to wrap up in a couple minutes. That point of like issues that stay for a long time. Like, do you, with the solutions that you talked about, which we can drill more in another potential podcast, but with that, do people sometimes still struggle with the issue or come back and like, that worked for a little bit, but again, that whack-a-mole problem, oh yeah, my anxiety is really bad, but it's not about, going to this place or driving. Now it's about worried about my girlfriend. Like, it's like same issue, but different place.
There are many potential ways that the sequence of therapy can be useful. And we all have this like once a week for a certain amount of time, and then we're done. But I have many clients who sort of drift in and out of therapy as they need it, almost like you take an Advil when you have a headache. We do a little bit of consolidation of what they had already learned. And after a few sessions, they're good to go back into the world. I'm not a fan of years and years of weekly therapy unless you have very serious problems, because again, that can lead to dependence. And so I really like the model of, okay, we're good for now. We kind of got where we wanted to be. Let's go try without seeing me once a week, or let's go every other week. Let's go once a month, and then let's give it a break. And if you need me, I'm here. Give me a call back.
Right. While again, acknowledging what I mentioned, that sometimes, like, again, in my process, it's like last week, I had this big revelation that didn't come when we started. It didn't come in the first 45 sessions. It came in year number 2.
Yeah. Yeah.
Which that's interesting when that happens.
And so, but there are also risks, as we've talked about in the beginning, from just going to therapy all the time. And so there are two sides. You might miss a real insight if you take a break from therapy, but there are also risks of staying in therapy when your functioning is actually quite good.
And again, to close the loop on this, when you're working with a particular person with a problem, fear, anxiety, clinginess, this problem that I brought up of it can, you can find a solution, or you can seem to find a solution, but then like I feel like a lot of people struggle with this, is like they seem to get to a place where it's good, but then the issue pops up again in a different way. Is that common, do you find?
It's very common, and for lots of reasons. And with anxiety in particular, there are good evolutionary reasons why anxiety will pop back up when it appears to have been solved. It generally actually helps us to survive when anxiety is sticky in that way.
And I know you got to go to close on that. So then what happens? So is it just further and further, more investigation? Where is that coming from? What does that part want? Further investigation of that fear. In my experience, I found like you got to revisit stuff like that a lot. Like it's like, again, what's happening again? Like, oh, I'm worried about this thing, or this thing's happening. Oh, it's that fear again. Oh yeah, that fear that we've done 5 sessions on a year ago. It's that thing again coming up. Like,
but usually you don't have to start all the way at the beginning, so you don't need quite as much each time, and so it's slowly kind of weaning you off with the expectation that this is probably going to pop up again, but now you have some tools.
And again, is it like what I just said, just more like investigation or probing into where it's coming from or what's underlying it, or is it more finding solutions?
It could be more practice, it could be more experiments, it could be more exposure therapy. It really depends on the client.
Okay, interesting.
All
Well,
right.
this has been very clarifying. I've enjoyed this conversation quite a bit. There's some deeper, or you could say more macro level, sort of sociological problems, which we didn't get into, about what's happening with kids, particularly, and the increasing rates of ADHD diagnoses and anxiety, panic disorder, OCD, things like that. But I'd love to have you on at some point for a part 2 if you're ever around to get into that more. But I really, but I really enjoyed this. So thanks so much.
Thanks for having me.
And if people want to, I don't know if you're open or soliciting clients or whatever, or if you have any kind of online resources or tools, is there anything you want to direct people to?
Yeah, my website is drcamiloortiz.com. So doctor, just the letters DR, and then my name, Camilo Ortiz.
Okay.
Or follow me on Twitter. And read Abigail's book, and she talks about me in there. And those are some places.
We'll definitely link to your website. Are you taking clients right now, or people?
Yeah, and we have some other people in my practice. So
you have, and is that only for people in Long Island, or do you do it online as well?
Lots of online therapy and licensed in different places. So reach out, and I'll tell you if I can see you.
And that's for kids, adolescents, and adults.
And adults, yes. I see the whole lifespan.
Yeah, and we should clarify. And for any like the range of issues, are we kind of really talking kind of the whole spectrum, or anything in particular?
Lots of different things. My website is a good place to check my expertise, but the most common thing that we see is anxiety and then big emotions, how to handle those.
And things like depression, OCD, PTSD.
Absolutely.
I know you said OCD, but depression, PTSD, that's a very difficult problem people struggle with.
Absolutely.
That's something. Okay, cool. Great. Well, people should check out your stuff, and if they want to look further, they can maybe even book a session. But thank you so much, and appreciate it.
Take care.
Has the dust settled from the COVID policy response? Far from it. The storms are many. Inflation, learning losses, ill health, high crime, broken government services, displaced workers, substance abuse, mass loneliness, discredited science, real estate crisis, censorship, and overweening state power. The world is on fire with war, mass killings, crime, hunger, revolution. The lack of accountability, or even so much as an apology, is a foreshadowing. They'll keep their newfound powers and try it all again. Brownstone Institute is seeking answers, undertaking important research and publishing the results while providing fellowships for dissident scholars who have been professionally displaced. It's not about this one crisis. We urgently need to restore peace, prosperity, and integrity in science and journalism. Visit brownstone.org for more. We may never get to the truth, but we can get closer to the truth. There will be no stopping the efforts.